I don't know. That's the critical moment I got disconnected. Sorry about that. Yeah. Welcome all of you. Today is the 7th session after the inauguration, so the 8th session of the brief course in psychiatric research. Good afternoon to all of you and all the faculty who are here, Dr. Dennis, Dr. Rama, and I'm sure there are others I can't immediately see on the screen. Thank you all for joining today. The 4 parts of today's program are: one is topic of registry by Professor Dennis Xavier, then the quiz, and there is a brief review of all designs quickly by Dr. Dennis, leaving about 45 minutes to an hour open for an open session where with all the faculty present, you can all ask your questions about all the designs and all the issues. So that's how we would go about it. If all of you can confirm that most of the trainees are here, we can say, please, we can start. Dr. Dennis, welcome. Would you be happy to start presentation on registry? I mean, after that, we go into quiz.
We can do that. I just got my cup of tea, so I was wondering whether we'll do the quiz first.
Yes.
As you know, I just finished the other session.
Right.
So
no. We'll do the quiz. No worries. We'll do. See, the thing we thought was, once the quiz means, then you do the registry, then you have to seamlessly move into the revision, which is fine. I think. I will remind you around the time we would request you to start the review of sessions. We'll remind you at that time. But please, you could start with the quiz.
Dr. Ashok, we'll take a short break in between, isn't it? And we'll do objective 2 for some time, so that'll give me a breather.
Yes, we'll have some objective 2 also, certainly. Then we have an open house, correct? That's right, yeah. So I hope all the group leaders can confirm that all the trainees are here. So we'll start with the quiz then. Okay, all right. Right. And then as per the original plan, I think if you for the first 1 hour, I think the chat would be disabled for the first 1 hour. So if you have some urgent comment to make, you can always unmute yourself and make your comment. Feel free. But for the first 1 hour, the chat would not be available. Please keep your questions with you. You can always put it in as soon as the open session starts. Okay. Over to you, Dr. Dennis. You could start the quiz for us.
Yeah, just before the quiz will be in 3 parts because at a time we can put up only 10 questions. There are totally 15 questions. We have, totally 25 questions, 20 questions from cohort and RCTs. They're all very simple, actually. Dr. Sri Lakshmi from group D, can you put off your video if you're going to be, thank you. If you're moving yourself, put off your video for some time and make sure your video is fixed. Otherwise, it's extremely distracting for people. We see your ceiling and it moves about, and see Sagar Garg as well. Please don't shake your video too much. Fix it in some place. In another group, actually, somebody told me, one is you should never use a mobile phone for, attending webinars because, you got to see data. You need to look at things, and however large your mobile phone is, it can never be as large a screen as a laptop. If at all, for whatever reason, you are compelled to use a mobile phone. Where's my mobile phone? I can't find my mobile here. Maybe I left it somewhere. Somebody showed this little hack. You can fix your mobile phone on this. So assuming that this is your mobile phone, you just see like this one, you just place it in this. It just remains stable. And of course, all of us have plenty of books. You can keep books and make sure it is in one place. Oh yeah, here's my mobile phone. I just found it here. And it fits in really nicely. You keep it here like this. Look at this. It just fits in. And it's a terrible thing to do, to have your video on and move it around. And some people walk with this and go, all over the place. And hopefully you're not walking to the toilet with it switched on. So that wouldn't be terribly pleasing for us to see. So there is some techniques and etiquette also when we are, using, are participating in video Zoom calls. Okay. That being said, somebody said chat is disabled, but it is still on. Please disable the chat, Mr. Sriram, for now, or send private messages to people so that it doesn't keep popping up here. Okay, so we're starting with the quiz. There are 20 plus 5 questions, 20 questions in RCTs and cohort, and 5 questions from qualitative studies. So you'll have 5 plus 5 plus maximum of 3 minutes for the last part. So we should be done in about 12 to 13 minutes. by which time I'll grab my tea and then we'll go ahead. So, Mr. Sriram, please go ahead. And can people see the timer? I'm not sure y'all can see the timer, but this is for 5 minutes, 10 questions in 5 minutes. And if not, Mr. Sriram will tell us when it is 4 minutes. Anyway, the time has started. Please go ahead.
Hosts and panelists are not allowed to vote, sir.
Can't mark an answer. I'll drop it 4 minutes. Not able to mark an answer.
Oh, you're not able to mark the answer? Mr. Sriram, maybe you should disable this then. Just allow it for everybody. Okay, just hold on. So, yeah, because our participants are all listed as panelists, so they can't vote. They can't score on this.
Yes, sir.
You just hold on a few seconds. In the meantime, we will. So anyway, you got a preview into the questions. Yeah. Okay, your time started. Please go ahead.
Just remember, like last time, you just keep scrolling down, you'll have more items. Dr. Smita Ramdas, please mute your.
Unable to submit, sir. Unable to submit.
Was anybody saying unable to submit? I think it should be possible. So or wait for some more time. Wait for some more time, and then once it's closer to 4 minutes, I think he'll allow you to submit.
It's possible to submit, sir.
1 minute more. We are done. Shall we go with the second one, sir?
Mr. Sriram, this is the wrong one.
No, I'm starting the second one, sir.
No, whatever you showed me, this is the
Uh-huh.
wrong one. This is not what we are supposed to do now. What I sent you today morning, you showed me correctly. This is the previous one that we did on 16th May. Even the date is up there. So could you just pull up the one?
Is this the right one?
Correct. This is the one. This is the one. Yeah, please go ahead. Your time has started on this one. You have 5 minutes for this 10 questions.
Hope the panelists are able to vote.
Yes.
I suddenly lost access to the poll.
Is it just you, Dr. Srilakshmi? Anyone else lost access to poll?
No, I got it back again, sir.
Great.
Sir, my thing has gone, sir. I lost my access to the phone.
Just swipe your screen and check, sir.
No, sir, it's still not coming.
We'll have to wait, sir.
Okay.
You've got 1 minute more. We are done.
Did it get sorted for Dr. Naveen? I mean, did it?
I just received again and I lost, sir.
We're going into the next poll, sir. This is for 2 minutes.
Okay, okay.
You've got 1 minute more. We're done.
That was helpful. I mean, I don't know if we can make a difference to Dr. Naveen. I'm sorry about that, Dr. Naveen. I don't think there's going to be any solution to that.
Sir, I just clicked and then it came as poll ended immediately. Can we do something about it? The last one. The last one. Just clicked and it ended.
For me also, it was the same. The poll.
Yeah,
ended.
for me too.
Same.
So this poll platform has been a bit unstable, looks like.
Last one, sir. Could you just do something about it, please?
If it's okay with Dr. Dennis, shall we leave it on for a minute so they finish it?
Yes,
Sure, no problem. No problem.
the last one. not coming. We are not able to strike it. It's okay. It's gone, sir. It just disappeared from mine. It's come back again.
Now, people having difficulties, are you using a mobile phone?
No, sir. Laptop.
Laptop only.
Laptop, sir.
Second part, before submitting, the screen went off, sir. I marked all the questions, but the screen went off before submitting.
We're done with part 3. Should we go ahead with the second part, sir? Dennis, sir?
Yes, please. Yeah, sure.
So should we do it once again if you have already submitted?
If you're already submitted, the report will be available, ma'am. So that may not be required.
Okay, thank you. Thank you.
Can just give people 2 minutes for this thing.
This slide has already come previously.
It's again coming up, so we have to attend.
Based on request, sir. If you have already done it, you can just leave it. The earlier attempt would have been already submitted.
Okay, thank you, sir. Thank you.
It's completed, sir.
Thanks so much, Dr. Dennis, for putting all this together, and Dr. Ramadevi for Ramash, the question from her end also. I think the quizzical questions, the perplexed looks, some satisfied researchers and some just not able to sit in the chair. I mean, those were my assessments as I could see when the quiz was going on. Anyway, it's great to see you all participate in this. Over to Dr. Dennis for the next part.
Dr. Ashok, I just lost audio for a little while, so I could see you talking, but I couldn't hear you talking.
Yes,
so,
I mean, you missed the gospel, Dr. Dennis. I'm sorry. You really missed the gospel. I'm sorry, you can't repeat gospels. So over to you. Sorry, I'll just say some very casual remarks in particular. Please go on, Dr.
All right. Do you want to just take a minute, Dr. Ashok, and tell people the importance of registries and why you thought of having this in this session as an exclusive one?
Yeah,
and
I mean,
since we don't have another faculty from psychiatry discussing this, maybe I'll put you on the spot. I was trying to text you. I couldn't find my phone to give you a few minutes. No, I didn't text you. So I didn't find my phone. So you have to do this extempore now. Yeah.
No, that's fine. I mean, I think, we had talked about cohorts. We had talked about, following up large groups of patients. registry is in a slightly different kind of animal. You're going to learn about that today. We have kept having references to that in the previous sessions, but it's a totally different thing to say I have a cohort of early onset alcoholism subjects whom I'm going to follow. You would have probably done it with certain specific objectives in mind. Registry starts getting more comprehensive, and you're going to hear more about that from Dr. Dennis, who's an expert with registries. He's kind of got quite a few registries under his belt, really. So you kind of put out a very, it'll be more comprehensive, more exhaustive, as it were, kind of giving all kinds of clinical information without, it can actually allow you for multiple different types of explorations as you follow this cohort. A cohort studies can sometimes be limited to what exactly your views are, what you're going to follow up. You can have a lot of information, but it's kind of defined within the parameters of the study that you wish to do. But a registry can be very, very comprehensive, obtain a lot more information, allows you to ask a lot of questions from it as you gather data over time. And very often, registries are gradually made available to other people also to explore questions on that. They're asked to kind of look at data and think of new questions they would like to ask. So registries are probably, if you say I'm interested in studying bipolar disorders or I'm interested in studying schizophrenia, I think developing a registry is it's a tough job, because you'll be wanting to put together a whole lot of comprehensive bit of information in it, and it has to be continuously updated in a particular way. But in some way, it can be, at the start, it can be relatively study agnostic. Correct me, Dr. Dennis, if I'm wrong with that. But because you can actually ask a whole lot of questions over time, so it becomes comprehensive enough to permit that kind of wider exploration. So we'll hear from Dr. Dennis what he has to say about registries. But just keep this in mind that it can be a little more broad than just having a cohort with a particular aim within a given study. Dr. Dennis, I don't know if I prompted a good job or not, but you can take off.
No. That was good. That was good and really useful. I've been doing registries for about 20 years now. So I'll share some of the principles. And there is a wonderful book which you can use as well. I'll share that also with you. So I'll share some of the studies that we have done. And I did a bit of, since we don't have a faculty from psychiatry this session who would kind of complement the principles I'd be sharing. So I did a little bit of reading on psychiatry registries and the APA, the American Psychiatry Association. They're doing something. So I figured that out. I'll share that also with you. Maybe some of you are involved in registries or you're aware of these things. So please add to that and give a psychiatry perspective. So with that, let's get started. But before that, I have a little request of you. I get a little distracted when chat messages keep popping up, and all of us are naturally inquisitive and we want to know that. So when you're teaching, when a chat pops up, then you get a little distracted. So I'll be doing a little less than my best. So my request to you is, Mr. Sriram says that some setting issues, so he's not able to disable the chat for now. So my request is, write all your chats maybe in a little sheet of paper like this, sheet of paper, and keep it with you, and maybe you can orally ask it, or you can, once we finish the session, you can put everything on the chat. The good thing about putting things in the chat is the moderator can bunch together questions, and we actually save a lot of time that way. So please put your questions on the chat once the lecture is over, but in the meantime, make a note of it and keep. All right, so with that, let me start with the session on patient registries. Are my slides visible and clear, please? Can you all see my slides?
Yes, sir. Yes, sir.
Okay, right, so let me get started. So what will we be doing today? We'll look at the purpose of patient registries, its uses, methods in terms of what do we call them, what are the different names, what kind of research questions we can ask in registries, comparison groups. Do we have comparison groups? We can look at that. Something called patient reported outcomes. which is quite popular in Western countries, yet to come up in India. Then we'll kind of towards the end, we'll look at observational versus interventional studies. This is the Psychiatry Association of America, the US, that has the Psych Pro. And then we look, as always, I have picked up at least one example from psychiatry, and these are my registries that we've been doing for some time now. And then if time permits, we look at something in endocrinology. It's a rare disorder, and how people have done it for a long time in Scandinavian countries. Right, so what is the definition of a patient registry? It's a system which uses mainly observational study methods. We collect uniform data and we have specified outcomes, right? And we evaluate specified outcomes, right? We define the population with a particular disease or a particular exposure as well, or a condition. And then we have a predetermined purpose. They could be scientific, clinical, or policy as well. The government can say, set up a registry in this area, and I want data from that to take policy decisions. So we can even have a policy question on this. What all can we do with registries? We can describe the natural history of disease. We can set it up and follow them up for a month, a year, 5 years, 10 years. There are registries ongoing for several years. The Indian Cancer Registry is going on for more than 25 years, being run by the ICMR. Right. So we can determine clinical effectiveness or cost effectiveness with healthcare products and services. And I'll give you some examples. Actually, there is an example from psychiatry over here. Clinical effectiveness or cost effectiveness, although towards the end, I have this discussion about interventional versus observational data and all of the challenges that there are there, even with the best possible observational study design. Right? We can monitor safety of drugs, of devices, of procedures, whatever. Quality of care, very important. I mean, I'm sure this is going to come up in India soon. It's very common in the West. And in fact, the APA, the American Psychiatry Association's ongoing renewal of license is based on the quality of care indicators that you submit to the registry. So as an individual, as a group, and as an institution, you need to keep submitting data. What are the kinds of research questions I can ask in the registry? Natural history studies, what happens, prognosis, clinical practice, patient experiences, clinical effectiveness studies. This can be related to compliances in the real world. Remember, this is not in a clinical trial setting. It's not in a well-defined control setting. It's a real world setting. And varying populations, they don't have a strict eligibility criteria, inclusion criteria, 7 of them, exclusion criteria, 32 exclusion criteria. No, they'll be kind of all comers is what should go into a registry, although there are inclusion criteria as well. Right? We have very broad eligibility, as I just told you, right? And then this can further lead to studies with greater generalizability. We can conduct more studies and we can make more conclusions with broader generalizability. What are the methods we use in registries? We use multiple study designs. It's not one type of a study design. It's not a simple cohort study alone. It can be a cross-section study. We can start with that, right? And then we can even stop there, right? But usually we don't stop there because we want outcomes data over a period of time. If you stop there, it becomes a simple cross-section study with a little value add here or there. Usually registries, invariably I would say, not usually, go on for a longer time. Registries use cohort or prospective designs with and without comparison groups. This is the interesting thing. I'll tell you about comparison groups as we go along. How do we sample and what are our analytical approaches? Sampling, several types of sampling we can have, and we can have some pretty sophisticated sampling techniques, and I'll not go into them now. When we do statistics and we do sampling, I will share those with you. This is a book. This is by the Agency for Healthcare Research and Quality, AHRQ. Does anybody recognize this symbol? If you've applied for NIH grants, you will you'll see this very, very frequently. This is from the US Health and Human Services, under which the National Institutes of Health in the US come. So this is the 4th edition. I used to initially use the 1st edition, and this is greatly improved. Registries for evaluating patient outcomes. It's a user's guide. It's a very detailed and a dense document, but a lot of the ideas that I'm going to share with you in the next few slides are taken from this document. Right. Where all do we use patient registries? I already told you about natural history or course of the disease. Variations in treatments and outcomes, that is something which is a key aspect, and the two registries, big registries that I was involved with, have done this largely. Examine factors that influence prognosis and the quality of life. We can describe care in patients, including appropriateness of care and disparities in delivery of care. And you will soon realize that there are many people interested. It is not only researchers who are interested in this. You will realize that researchers are doing less and less registries, and there are several other people. When I say researchers, I mean clinical researchers like you and I. Okay, right? And to assess effectiveness, remember there is a difference between efficacy and effectiveness. Maybe we'll discuss this during the Q&A later today. We can also monitor safety and harm with the quality of care. Now, who are the different people who are interested in this, and what benefits do they get out of registries? Clinicians like you and I, right? How do people present with a particular disease? So the first reports in COVID, they were case series to cross-sectional studies, and we have an idea. Oh, this is fever. This were the symptoms of COVID-19. Right? So quickly all these data came out. We can even say those were registries. So how this disease presents and what are the outcomes on large numbers. So people quickly develop pneumonia, and after some time we realize, oh, there is thrombosis. Right? It took us a couple of months before autopsies were done, and now of course we know thrombosis is such a common and an important aspect in COVID as such. Right? And we get this in the real world picture. We get to know treatment practices and outcomes. We need to once again keep in mind these are observational studies. We're not doing anything. We're just going to collect data from what is already happening. Physician organizations. Let's say, for example, the Psychiatry Society of India or Psychiatry Society South Zone wants to know how is schizophrenia being treated in South India. How are we treating autism? And what are the emerging treatments? Who's doing what? And is there a difference between tertiary care hospitals and primary care? And secondary care hospitals? Is there a difference between single practice psychiatrists versus group practice versus academic versus corporate hospitals? Right. So. And also these organizations can assess if the management is according to evidence-based guidelines. So on one side, this is our reports, and we have periodic reports. We're not waiting till the end to provide data or to say final results. No, we can interim keep providing data. So this is, and I remember one particular report that we prepared for a study wherein on an ongoing basis, the plan is to, this is your treatment patterns for this condition. This is the overall country's pattern. And this is evidence-based guidelines. So you can see where you stand. And these reports are sent only to that site. We don't publish that. Right? So what are we doing? In real time, we are improving quality. Imagine if we have a registry of 25,000 people in schizophrenia being followed up for 10 years. And every 3 months, every 6 months, you're getting reports on how
recording in progress.
Mr. Sriram, do something about it.
I don't know who pressed this button.
Please don't.
Recording stopped.
Yeah. All right. I don't. Okay. Right. Okay. So I was telling you about. Oops. Any interruptions? Then the computer behaves a bit badly. Okay. Right. So whether it's according to evidence-based guidelines, so I was telling you, imagine you have a cohort of 25,000 schizophrenia patients of varying ages, gender, socioeconomic status, tertiary care, secondary care, single psychiatry clinics to group practice. You have all of that, and the Indian Association or Indian Psychiatry Society, I think that's what you call yourselves, is monitoring this in real time and providing feedback. The idea is to improve quality of care. And this can be done beautifully. And now with software and with technology and access, this can be really fantastic. And those of you listening to this, maybe you should get super excited about this idea. And then maybe some of you get together and come up with plans on what you can do. And it's so easy to set this up. In a matter of days, you can set up databases. Matter of days means 3-4 days. You can set up databases, provided we agree on what we want to do. right? So insurance companies, the government, employers who are paying for their employees, medical care, they're also interested. How these procedures, devices, or drugs are being used. Is it really, is there overuse in some place, underuse in some place? All of this can be looked at, right? Effectiveness in different populations. Remember, we're talking effectiveness. We'll discuss effectiveness and efficacy later on. Drug or device manufacturer, they can say, okay, this is how if it's plenty of registries on stents, on different procedures and implants. Of course, needless to mention drugs, right? Devices, procedures as well, and for that matter, even training and some therapeutics, which you people may be interested in as well. Let's look at some naming for patient registries. What are the different names? One is, we can call this a product registry. My focus is the product, it's not the patient, it's the product and how the product is doing, right? Of course, it's being used on a patient. Health services registries, how are these OPDs running, right? How are hospitalizations? How many people come to the OPD? What happens to people? How many of them get hospitalized? What are the hospital outcomes? What are the procedures in hospital? Or the whole episode of care from the time the patient was diagnosed with this particular condition. Let's take tuberculosis, which lasts anywhere from 6 months to 1 or 2 years, let us say, right? From the time they were diagnosed, sputum positive, till they were declared. So if you have a registry that way, another 10,000 patient registry, there's so much of rich data one could derive. Right? Yeah, disease or condition registries. It could be something as common as myocardial infarction or strokes, or something very rare, rare disorders, rare cancers. All of these registries can be held. Right? So we can have just a descriptive question or a very focused question to support decision making. It can be a very broad question or a very focused question, and these questions can be on effectiveness, and I've told you about this. So I'll go to some newer ideas and let's look at some examples. Comparison groups. Why do we want to have comparison groups in observational studies? To strengthen our understanding of whether effects that are seen in two different groups are real. Of course, I'm sure we just finished the RCT discussion, and you will come back and argue with me, can we really compare? At no point will the most sophisticated observational study be able to even hold a candle to an RCT. Still, there are certain situations. In fact, there's a very dense chapter in this book that I told you about, in situations where you cannot do randomized controlled trials. It may be unethical, it's not possible, or sometimes the treatment may be potentially quite harmful. So you can't invite patients for that. But in clinical practice, that's only treatment available, right? So you cannot randomize them into treatment versus control. So only patients who consent, who are ready to take that risk, we can learn. So there are situations where there is no clinical equipoise, and therefore you cannot do trials, and then observational studies are done. Right? Depending on the purpose, control groups can be internal, external, or historical. I'll not go into this. Internal, simply go into too many details. Internal is within that group, right? We can have controls. External, in similar patients or similar individuals from another group. Historical, from the same group, which happened 3 years back, 5 years back, and similar patients we could take, right? And what do we want to use this? So if we have two options, we have 3 options or 5 options, let's keep it simple and say if there are 2 options, I want to see the difference between these 2 options. Is that difference, and how big is that difference, right? And is there a strength of association between those 2 groups? That is something that we could look as well. Now, how do I ensure that my groups are comparable? What strategies do I employ? Right? I'm sure you'll very clearly recall, when we randomize, we put them into 2 or more groups, and the groups are similar in all ways except the intervention that they're going to get. Right? And known and unknown confounders are taken care of. That is one of the questions in today's quiz. You'll recall that. But in an observation study, what can I do? Right, there are techniques to deal with that, right? So one is we can have individual matching, right, based on age or gender, disease severity, whatever. We could have based on inclusion criteria. I will only include stage 2, right here, and I'll include similar stage in the other group. The other, what is most commonly done in large databases, is matching by statistical techniques. Hopefully you'll have heard this propensity matched scoring or propensity matched comparisons done, where parameters, we take hundreds of parameters. I read a study where there were about 260 parameters on which they were matched, and they had a particular scoring. And of course, this happens with large databases and reasonably complete data. If data are not complete and reliable, there are problems with that as well. So this is called propensity matched scores. Last couple of concepts before we go into examples. One is called patient reported outcomes. This is data or a measurement that a patient reports directly. So it comes directly from the patient, and in fact, patients have access to the database and then they can enter it themselves from their mobile phone, from their laptop or tablet, right? And there is no amendment or interpretation by the clinician. See, the patient said this, and okay, this is on this quality of life scale. It's maybe 3 or maybe 7 is what we interpret, and so sometimes there can be biases there. But here, patients report directly. There are certain things which are straightforward, and one can straight away give that, but sometimes it's a little more challenging. Right? So therefore, patient-reported outcomes, we have to ensure that they have certain characteristics. They're valid, reliable, responsible, interpretive, responsive, interpretable, as well as translatable. So all of this we need to keep in this patient-reported outcomes. Let's take two different examples of patient-reported outcomes. One is overall survival. So every 6 months, you keep asking the patient or their close relatives about their status. Are they alive or not? As simple as that, right? And next is about tumor response. Of course, with something like this, they may be even coming to the hospital on a regular basis. Even if a central agency and not the hospital is conducting it, there are some ethical issues towards that, around that. But in Western countries, they're able to do that. A central agency, which is not the hospital and not the treating doctor, they are able to collect data directly as well. We can also have others such as quality of life, pain, breathlessness, physical functioning, chest pain, whatever. And I'm sure you can come up with several in psychiatry, although it will be a little more challenging. I'm sure some of you are going to come back and say, no, with psychiatry, patient-reported outcomes may not be that easy. And these are the reasons why. So I'll urge you all to keep this in your mind and please add value to this discussion towards the end of this discussion. A bit on observational versus interventional studies. Right, we need to keep in mind that these two are complementary and they're not competitive. One is not better than the other, right? So intervention studies, of course, they provide the highest level of evidence in the ideal world. Inclusion exclusion criteria. I have my liver enzymes, I have my cardiac enzymes, I have my renal function, all that. Okay, they passed all that, then they enter the study. Right, and then they monitored, and then at a point in time, we stop medications, we change it, modify, etc. And in an ideal world, we look at efficacy. What is the best possible effect of this particular intervention? Right, observational studies are for broader populations. We understand the actual results, including safety, in a real world practice, and some people would like to call this effectiveness in a real world setting. That's how it's eventually going to work, right? Of course, first we need to demonstrate efficacy, and then the real effect is when it goes into the real world, which will be less than what it is in an ideal world. Okay. Towards the end, I found this on the internet. I was looking for this yesterday, and I found this psychiatry patient registry online. Probably some of you know more than me on this, and I would invite you to speak about this after I've shared a little bit of what I quickly went through. So this was launched in 2017. I found a document in 2016 saying it's going to be launched, and this is the American Psychiatry Association sponsored registry, right? And this was created, and I'm using the words directly from their website. To meet the current reporting requirements for quality improvement initiatives in the country, as well as to demonstrate how they are doing at delivering evidence-based care. So they and from their EMRs, from their electronic medical records, there are possibilities. These you don't have to sit and key it out. You institutions allow access to their database, and there is a system by which they extract data on a periodic basis. All we have to do is understand and accept the scientific question and procedures there, and allow administrative access. And then on a periodic basis, they collect this data and then they send it back. I'm presuming Psych Pro is also similar because I'm familiar with the cardiology research, registries that are ongoing, and they use systems like this. There was this National Registry of MI that was running in the 1990s and early 2000s. Yeah, 1990s. They had 1.5 million, that is 15 lakh cases of acute MI all across the US, and there's some incredible, reports they were giving out. Now, this registry is also to fulfill the American Board of Psychiatry and Neurology's requirement, right? To maintain their certification. You need to say, this is what, I'm doing. This is how I'm treating schizophrenia. This is how I'm treating bipolar or depression, or this is my regimen for anxiety, whatever. And say, okay, you're doing a good job, and you continue the certification. I'd invite one of you to make a comment on this, on if and when this will happen in India. I'm presuming it's not happening in India in psychiatry. So with this, let's take a couple of examples and I'll be done. So this is 2014 by the group from AFMC, Jyoti Prakash, probably you all know him. This is not a systematic review, this is a structured review about central registry in psychiatry. Maybe something similar to Psych Pro that we just saw in the previous slide. So let me go straight away. Okay, so they looked at Medline, Scopus, Embase from 1990 till date. So this is about 20 odd years, 21 years or so, right? Available data was systematically reviewed and analyzed. By analysis, this is not a systematic review, this is not a meta-analysis. They just put together the ideas that came there, right? And these are the results they got. Central registry were found useful in epidemiological analysis, association studies, outcome studies, comorbidity studies, forensic, effectiveness of medication, qualitative analysis, etc. So this paper contains, paragraphs this size about different registries that they decided to put in this paper. And I was excited to see an Indian name there, some Raj Chengappa, I think, but that came from Pittsburgh. So maybe some of you know Raj Chengappa in Pittsburgh. So this is the conclusion of this paper, right? The findings aptly highlight the role of central registry. Okay, role of central registry as a valuable tool in research. Relative lack of such registry in Indian context handicaps us significantly for robust clinical research. A centralized registry system will yield a wider and better picture of our practice and lacunae in the system. I'm hoping some of you are going to come and say, this is an outdated paper, we have fantastic registries running. I have not done a systematic search into the registries that are ongoing. This is the Danish schizophrenia registry published in 2016. Right, this has 21 clinical quality measures in diagnosis, antipsychotic treatment, adverse reaction, cardiovascular risk factors, lab, family intervention, etc., in schizophrenia. Right, and right, so this is what this is another paper from the same registry. So they had, I missed the number actually, they had about 3,000 odd schizophrenia patients. If you total this up, it is about 3,000. And so this is admission volume and quality of mental health care. So low volume care or low volume centers, medium volume, high volume, and very high volume. So these are the results of the quality of care in medium versus high. I'm going to stop sharing the slide for a few seconds, and I'm going to ask you people. So you saw the research question, the question there, right? I'm going to show you that table, unless you've already seen this paper. Medium volume to very high volume. Where is the quality of care better? Can one of you just unmute and speak? High volume, very high volume versus medium volume. Where is the quality of care better in schizophrenia? Please unmute and speak quickly. I mean,
I feel it is in low volume, the quality will be better, sir.
Low volume, quality of care will be better. Dr. Sanjay Kumar, thank you for that. Anyone else agrees with him, want to look at it differently? Let's have one or two more. Dr. Ramesh?
I think medium volume, sir. Medium volume. Quality.
Medium volume, yeah. Medium. So low volume, the quality of care is better. Okay, so let me go back to the slide now. Let me go back to the slide. And this is the result. Okay, so this is psychiatry unit admission volume and quality of care among patients recently diagnosed schizophrenia. So they had a way to look at the quality of care. So we are not going into that. So this is medium, high, and very high. This is the total number of patients, more or less the same, 870, 960. Look at the percentage of people who received high volume care, high quality care, and this is the relative risks, right? So compared to low volume, medium was 19% better, not statistically significant. High was 13% better, not statistically significant. Very high was 40% better, and this was statistically significant. So the opposite of what we thought, right? I would have thought about it the same way because we are in an Indian paradigm. Okay, when we say high volume, you're seeing 40 patients, 90 patients. 90 is too much in psychiatry, I would presume, right? So high volume. So there, high volume gave better quality of care. So this is something for us to think about. Let's look at, and we need to keep in mind we're talking about Denmark, not India or other Asian or African countries. Let me tell you, this is my first baby, so I'm going to be very happily present this, and I'll also explain a bit of statistics in this that we did. Right at that time, I'm talking about 2001, so exactly 20 years back when we designed this. At the time, we said, so at that time, we had limited data on patient characteristics, treatments, and outcome. Now, of course, we have a bunch of papers. So Dr. Prem Pais and I, we set this up. We had 10 regional coordinating centers, and we collaborated with McMaster University. And funding was from 2 academic institutions, and 1 pharma company gave us a little bit of money, but they're not the sponsor of the study. So we had 89 centers all across the country. I would like you to look at the gaps over here and the gaps over here. Right, so we didn't have centers there. Not that we didn't want to take centers, but I'm sure you would appreciate there are not many high quality hospitals there. So we also had 10 regional centers. So the yellows over here: Ludhiana, Delhi, Jaipur, Mumbai, Nagpur, Kolkata, Hyderabad, Bangalore, Chennai, Cochin. So these 10 were the regional coordinating centers, and from there we had another 8 to 10 centers around them that participated in this registry. So we collected data at admission and discharge, and only 1 month outcomes. We collected data from 20,468 patients, 89 centers, and 50 different cities of India. So this was published in the Lancet in 2008, and as I told you, this is my first baby, I would really say, in terms of as a major publication. And we had people from all across the country. So these are my colleagues from Canada, and these 2 people, now they were at AIMS Delhi at the time. Now you recognize this name as the president of the PHFI, and these are people from Jaipur. This is from KEM, and in different places we had people. I'll go to, this is the editorial that came along with the paper, and I wanted to highlight a few points in this. This registry is a major milestone as it provides the first comprehensive view of acute coronary syndromes in India, right? Then a problem well defined is half solved. They say that the authors must be commended for defining. The next steps is to define and implement measures for primary and better secondary care or evidence-based treatments, and etc. This is what their comments. So now, on day 2 in 2008, there were more than 3,000 to 4,000 hits on Google with this, and even the Wall Street Journal wrote about this. People in China wrote about this. The BBC, I had 2 interviews with the BBC on this, including one in Hindi, which my colleague and I did jointly together. But this was very interesting. And what did we find? I'll tell you why this got such high impact in the next couple of slides. Right, so we screened 21,000 closely, and about 500 did not have conclusive ECG. So 20,468, so 12,400 with ST elevation MI and 8,000 with non-ST elevation MI, and we had about 95% follow-up in this. Right, so in terms of methods, prospective multi-center registry, and I've told you about this. I'll tell you a little bit about the statistics over here. All right, so between group comparisons, independent sample t-test, categoric variables, chi-square test, these are pretty straightforward. Then for the others, we had the Mann-Whitney U test, and also to validate socioeconomic status, we used Cronbach's alpha. And coming down, we did multivariate logistic regression analysis in multiple steps, and I'm going to show that to you. Multiple logistic regression analysis to look at the association between socioeconomic strata and death. Right, this is what got people excited, and I'm going to share mainly that data. So these are patient characteristics, and mean age is 57, which is about 10 years on average, 10 years younger than what we see in Western countries. From emergency room to thrombolysis for ST elevation MI, it took 50 minutes. The guidelines even at that time was less than 30 minutes. That means in India on average we are more than double the time. We're not talking about traffic. We are talking about after coming into the emergency room, it took them so long for thrombolysis. We are not talking about primary PCI or with stent, bare metal or drug-eluting stents. We're talking about just thrombolysis, which just cost a couple of thousand rupees even at that time. Then, at that time, just 5.4% used an ambulance. But now things have dramatically changed. 3 days after this, the health minister made a remark about having better emergency care. Now, I don't know, we cannot find it unless we speak directly to the health minister's office, whether it was based on this paper or something else. And at that time, 3/4 covered all costs of hospitalization out of pocket. So in about 15 years, things have changed in terms of ambulances and insurance as well. And there are a lot of improvements in our country for sure. This is how we document risk factors, clinical features. I'll not go into that. This is treatments in hospital for STEMI and non-STEMI, all different drugs. We can document it, we can analyze it, etc. Outcomes at 1 month, death, reinfarction, cardiac arrest, stroke, bleeding, etc. We can look at all of that. This is variation by socioeconomic strata, and I'll spend a little bit of time on this. So we categorize people in a simple way into rich, upper middle class, lower middle class, and poor. And we statistically validated this because we had to keep it very simple. We cannot ask elaborate data, right? So firstly, the lower middle class and poor is over 70% who made it to hospital. So this is not a disease of the rich. And we had all kinds of hospitals. We had government hospitals, big hospitals, small hospitals, including corporate hospitals. So this is not just a disease of the rich people. So 70% were low middle class and poor. Now you will notice here that all treatments except antiplatelet, and at that time antiplatelet was only aspirin, which cost a few paisa, all of them were highly statistically significantly different in the poorer people compared to the rich people. And you see this p-values with so many zeros in it. Let's take just a couple of examples, right? Thrombolysis 61% here, 52% here. Right, so let's take lipid lowering drugs, 60% here and 36% here, kind of half. ACE or ARB, 60% here, 54% here. Angiogram, which is important for diagnosis, 41% here, 1/5. PCI, 15%, 1/7. So 2 out of 15. CABG surgery, this is bypass graft, 7%, 7.5% here, 0.7, 10 times different. Are the arteries in the poor different from the rich? Anyways, this is mortality. This is crude rates. 5.5, this is at 1 month, 5.5% in the rich, upper middle class 5.1, lower middle class 6.5, and poor 8.2. And when I saw this for the first time, I didn't, there is a difference over here. But friends, one of the things that I keep telling my students many times when you're looking at data, the first one is quickly eyeball the data. You will get a lot of insights before you even do statistical tests. Let's take this as 5 and let's take this as 8. The difference between 5 and 8 is 3. 3 out of 5 is 60%. 3 out of 5 is 60%. That means there is 60% increased mortality in the poor compared to the rich. Now I do this, but when I saw it at that time, yeah, 5% and 8%. But now it hits me that it is 60% higher in the poor. No wonder you have so many zeros on the p-value here. Then we begin to explain. So I'm working on a logistic regression analysis, working on explaining logistic regression analysis as to what we do and what we get and understand by it. We will do all the statistics later. Right? So what is this 60% difference in the poor compared to the rich due to? I did not show you, I did not spend much time explaining this to you. Risk factors were different. Known hypertension, known diabetes, smoking, diet, stress levels, all of that were very different in the rich compared to the poor. So let us say, okay, let us adjust for it. That means let us remove this difference and get adjusted rates of mortality, and let's look at the odds ratios as well. So here are some numbers. So these numbers 5.1, 5.9, 6.7 and 7.9 are adjusted death rates after adjusting for risk factors. Okay, now what do we see? We still see a difference, 5.1 and 7.8, more or less, a little bit reduced here, little bit reduced here, and this is more or less the same. And excuse me, right? So next is I have the odds ratios and the 95% confidence interval. So I fixed the odds ratio for rich at 1. Compared to the rich, there is 16% increased mortality in upper middle class, 32% in lower middle class, and 57% more in the poor. And you see this highly statistically significant, and the p-value remains more or less the same. So you still see the 60% increased mortality. So what I learned from this is the difference in risk factors did not affect mortality. What else is different between the rich and the poor? You saw it in the previous slide, treatments. So now the next step, we adjusted for risk factors and treatments. So for a moment, look at these, come right to the bottom, please. Just follow me here. Don't look at those numbers. Risk factors: age, sex, prevalence of MI, hypertension, smoking, blood pressure, Killip class, and BMI, including patient risk factors and clinical features, both. I should add that here as well. But treatments, the type of hospital people went to, how long they took to come to hospital, what were the drugs they got in hospital, what interventions they got. So all of these were put in the regression model, and we have now further adjusted rates of death and odds ratios. Sorry. These now are the adjusted rates of mortality. 6.9, 6.9, 6.9, 6.9. Everything is the same, right? I know there's a 7 and this is 6.5. You see the same. If you don't believe this, look at the odds ratio. This is 1, 1, 1, 1. This is 1. What does this mean? If the poor got the same treatment, irrespective of whether they were young or old, whatever treatment they took, whether they were smoking or drinking or they were stressed out before coming here, if they got the same treatment as the rich, 60% of their lives, here is a 60%, 60% of their lives can be saved at 1 month. And there is, I mean, I have not shown you the data. On average, the poor people are 10 years younger than the rich people in this group. So these are sole bread earners. And so in the end, I mean, yesterday we were having a webinar on something else, some related to health policy, etc. And one person said health equals politics. Anyway, I'll not go further into that. Just keep that in your mind. And this data shows you this. So I did my best to also explain logistic regression analysis. What are the meaning of adjusted rates? How do I read and interpret odds ratios and its 95% confidence intervals, and what the p-value means here. Right, so this is another way. So this is adjusted for risk factors. You see this difference still remaining. And once you adjust for risk factors and treatments, it remains the same. And you know, the 95% confidence intervals are crossing this line. Right, so I'm just going to rush through the next couple of examples, and then we'll open up for discussion. So this is a large hospital registry in acute strokes in India. This is funded by the NIH and another group in the US, and there was a portion of the study that we also funded. So I got a grant from the NIH to do 3 studies and run a training course. This was a $4.6 million grant that I got in 2009. We ran this program, we ran this program for 5 years, and the study was part of it. So this is a 6-month follow-up, multi-center countrywide. So deliberately we wrote a countrywide stroke registry here, and I'll tell you. Sites were invited across the country. They were stratified by region and population. This is to ensure representative samples at site. We included consented patients, including those who did not consent. So when I take the session on ethics, you ask me this question: how did you manage to take patients who did not consent? We also took patients who came to the emergency room and were not admitted in hospital. Aren't we missing these two people? If we take only those who came to hospital, they were stabilized, and we'll miss people who came to hospital and who died either in the emergency or within a few hours or within a couple of days in the ward. So we try to make this as inclusive as possible. Many of the loopholes, many of the responses that I wrote to the Lancet reviewers, I tried to sort out in this Inspire registry. So do you see these gaps are filled up here now? Northeast, we had patients, and to some extent we have in the central area as well, but there are still gaps over here and here, right? So we try to have north, south, east, central, west, northeast as much as possible representation. So this is how I'll not go through this data here. Again, you will see low, middle class, and poor. Lots of patients here. 80% of the patients were low, middle class, and poor. And this is ischemic and hemorrhagic. This is tobacco, alcohol. This is treatments taken. I'll not elaborate much on that. But a few things that I wanted to tell you as psychiatrists, maybe you'd be interested. So this is, this is patients with a Rankin of 3 to 5. Rankin is a scale of disability, and about 50%, more than 50% of people are disabled at 6 months. People who survived at 6 months, about 50% are disabled, right? And if patient is disabled at home, who takes care? 90% of the patients are taken care of by family member. Oh, how nice, Indian people take care of their patients. They take care because they have no other go. They can't afford anything else. And I'm sure you people, are really concerned about the caretaker burden, and you can imagine what's happening here with somebody full-time in the bed and etc. So people, at 6 months, if they had an employment, if they resume employment, right? Only 42% resumed employment, right? That means 60% lost their job. Okay, I will skip all this now, and I'll end with this one, which is I wanted to tell you. I mean, these people are the world's best in conducting registries. Scandinavian countries and UK as well, Canada also, they do have, right? So this is first time report of Graves' disease, right? And with at least 6 months of anti-thyroid drug treatment. It's a small number of 290 patients, 19 patients. Remember, Sweden is a small country, but they did this for 10 years. They collected patient data for 10 years, and then they followed up again for another 10 years. So 830 observed patient years of data they did, and then they did survival analysis, log rank test, etc. So these are some of the characteristics, and I'll not go into the details of this. So with this, let me stop and open up for questions on registries.
I would request, thank you, Dr. Dennis. I would request trainees to just unmute yourself and ask questions if you can, and we'll have a look at the chat separately later. I also welcome all the faculty who have been from psychiatry, who've been helping out with various designs from the word go. So welcome to Dr. Sandeep Brewer, Dr. Rama Devi, Dr. Pratap Sharan, and Dr. Janardhan Reddy, Dr. Jagadisha. Thank you all for joining us. You could, I invite it from now on, I will take it like you could ask, you could kind of add to the idea of registry. I know Indian Psychiatric Society tried some kind of a nationwide sampling. They kind of support small studies where 10 centers join together and keep data for 1 month, that kind of publish it, through which we come to know some simple things about what are the common antidepressants used in the country and so on. So they could probably be coming closest to the idea of a registry. But I'm sure even the trainees have got an interesting angle on how they can gang up with each other across the groups that have now formed and actually start keeping data which for a period of time can start providing very valuable information. So I would throw it open for both the trainees and faculty to trainees to ask their questions and faculty to make the comments. Yeah. How are registries different from databases, and what is the prospective registry?
So maybe Dr. Ashok, for me to rest my throat a bit, we could have some of our faculty to make some comments, on psychiatry registries, as well as the, and of course, I'll take these questions as well. But maybe Dr. Sandeep and others can make some comments on their experiences of setting up registries and what more we could do.
Can I speak?
Yes, Dr. Sandeep, go ahead.
Yeah. Unfortunately, in India, we do not have too many registries. But for example, in Indian setting where we use too much of psychotropics in females during pregnancy, I have always talked to my colleagues that we need to start some kind of a registry that we maintain the data about whatever are the outcomes in females when they are receiving psychotropics. So if we try to so-called design a nationwide registry for this kind of a data, maybe we'll end up getting some data which is currently not available. We only get few case reports here and there. So that kind of registries needs to be planned in this country. But a lot of Scandinavian countries have a significant amount of registries and they keep on publishing their data. So that's my experience with the registries. Small registries which are there at different centers. Although I don't know whether we can use that as a term registry or not, that many times that we maintain the treatment, the kind of treatment which we provide and the outcome which get for those patients. For example, just maintaining the record of the ECT services in your center or across the different centers, that can itself act as a registry that you are trying to get some kind of a data, how people perform with ECT, let's say while they are receiving, how they do, what happens to them in the long term, and how they perform. So those kind of things can be planned out. Thank you.
Jagdisha, would you like to share anything about ECT registries? Dr. Janardhan, about OCD registries?
We don't have, sir. I mean, it costs money. I mean, it is not free. So unless there is a funding support, it is difficult to maintain a registry. We are about to start a clozapine registry in NIMHANS. We have made some. We have agreed upon some standards to be followed, which we will be sharing with our colleagues in NIMHANS, and we will have a registry to see to that all standards are met in clozapine treatment. And over time, we are planning to do regular audits to see whether we are meeting the standards or not. So it's a small.
Yeah, Dr. Jagdisha, on the topic, because you specifically mentioned the need for standards across different teams and within demands. The question by Dr. Shiva asks, in India, where the clinical practice is so different in different settings, government and private, how appropriate it is to set up a registry? Your comments on that, Dr.
Jagdisha? I think, see, there are certain things for which there can be no compromise. Like, for example, getting a hemogram done, TCDC done for clozapine, there can't be any compromise at all. So for such things where there is a wide acceptance of certain standards, I think there can easily be some standards that can be set. I don't think anybody will dispute that count. Of course, there are people who do say that in India we don't need as rigorous TCDC monitoring as it is required elsewhere, but that is sheerly out of our ignorance. We don't know how many people may be experiencing granulocytosis and dying, etc. I know of people who have died suddenly after they were put on clozapine. We never know how many of them would have died because of very serious adverse effects like myocarditis, pulmonary embolism, etc., which are known with clozapine. So unless we keep a very strict vigil, we are likely to miss out. So ECT is one such thing where standards can be set easily and everybody is expected to follow. Clozapine is, I think these are some of the things that are, one can conceptualize a registry very easily. And Sandeep's suggestion about keeping the registry of pregnant women on psychotropics is an excellent idea. I don't know whether Lakshmi will know if there is anything already. Lakshmi is in group B. She worked in the perinatal clinic closely with Dr. Prabha.
Hello. Sir, we just have data on pregnant women attending our clinics. I don't know if we do have data on what antipsychotropics they were on, and etc. But I don't know if it will amount to a registry.
Yeah. On that topic, Dr. Jagdish, I mean, I actually remember, I don't know if they're doing it now. Now they're really become very big. These Cloud9 series of hospitals that opened up in Bangalore, because they only deal with just pregnancy and delivery. And I knew that Dr. Kishore, there was for a year actually he maintained, and he would actually call us frequently about the medications that he was finding in these patients, and he would actually ask us to follow these children's. I mean, the children were just that it became they probably became too large, and I've not heard from them in some time. So yeah, I mean, I think it's a valid thing, and we probably need to liaise a lot with different departments if you have to actually set up these.
I think there is enough spirit and motivation to do this, but unless somebody supports it financially, it is going to be very tough. So, I don't know. I mean, Dr. Dennis would have received some grants for doing that registry. So
That's
yeah,
what you mentioned. Yeah, that's true.
yes, we have. I mean, I don't even know whether there are agencies which will grant money for maintaining registries. You do research, they will give you some money. But if you say that I will make a registry, will people give any money? I don't know. That's a money is almost everything.
Right. Dr. Pratap?
ICMR gives money for setting up registries, and India has some good registries in other areas. Like cancer registry obviously is a very strong registry. There is also a registry for diabetes now, so it's possible. And I think NIMHANS was in talk with ICMR at one point of time for a child psychiatry registry for South India, but I think because of COVID and other things, it got stuck somewhere. Yeah, the other thing which I would like to ask Dr. Dennis is about whether Sentinel site registries can be developed at a relatively low cost, in the sense that for certain things like clozapine, you may not need a countrywide registry. If you had a registry of 4 or 5 or 10 centers, that may give you good data, and that may not be as high cost as having a nationwide kind of a registry. Similarly, the kind of history that Dr. Sandeep was talking about, where you are monitoring pregnant women, maybe again you don't need a nationwide registry, maybe a Sentinel site registry.
Right, absolutely, Dr. Pratap. We could have a few sites. We can set it up as Sentinel sites, and we don't even need huge numbers like this. But the key thing is to go on for a long time, so that the numbers accrue as well as patient years accrue, both of them, and only then you get good data. I agreed with almost everything that Dr. Jagdisha said so far, in the previous weeks. But here, I want to look at one thing slightly differently. While I broadly agree with what Dr. Jagdisha said about you need money for everything, I would say prior to money, you need that keen interest to do it. And we can do this at absolutely low cost. Now, only when we add bells and whistles to all our plans, then all the money goes, for the bells and whistles. So the key thing is to keep the question. I mean, I told this in my presentation. You can have it broad or you can have it focused. Let's take a simple question about antipsychotic use in pregnancy, right? And then you're really passionate about this, and let's say in St. John's, maybe Dr. Ashok, we'd have possibly maybe could be 300 people per year with antipsychotic use in St. John's, possibly, and you have 10 centers like that. You have 3,000 people What do you need? You just need your first year PG to enter this data on a database that is available free of cost, and these databases can be set up just like that, and then they just keep entering data, and then a group of people analyze it in real time, and then run it for some time. So agreed, setting up the database, etc., will take a bit of time, but it's not so expensive. That's what I want to tell you. Now, for example, I mean, if you ask me, that NIH funded study, we spent a few crores of rupees on that. We had close to $5 million in that. So we could allocate, and then we actually paid people to actually even verify data, because NIH, they had lots of issues related to data quality and ethics and confidentiality and all of that. So we had to spend money because they wanted that level of scrutiny. That's why we are spent, most of our money was spent there, at the sites, to pay them and to get the data, etc. So otherwise, we can actually set it up at really low cost.
Yeah, Dr. Renes, just to quickly, because we know we'll be short on time. So if you can just, if there can be a positive message to the trainees about how they can network and actually conceptualize this idea of registries. And then we can move on to objective 2 and then go to the open session.
Yeah, so I think one of the outcomes of this endeavor that we have now should be a group of people, at least in South India now, this is the South Zone, getting together and getting excited about a research idea. This is something, and that excitement is the fuel, that's the adrenaline, and it'll cover everything else. Right? And once you have that, and most of you are mid-level to even senior people, and you will have funding for other research. The key thing is to, one, get excited with the research idea, and keep in mind that we can actually do this at low cost, including no cost. Okay. Now you can set up databases. And for example, St. John's and most other institutions will have RedCap. RedCap is a very robust database that comes from Vanderbilt University in the US, and you can get an institutional license. It's an extremely robust database. We are using it in St. John's for so many things, and you can just set up RedCap. And people can, from their mobile phone to tablets to wherever they are, they can just keep entering data. Literally free, other than those, I would say it'll take about a week or so to set up the database. If somebody sets up the RedCap database, you can do that. Okay, so that's one thing. But it's important for us to get the research questions right. What are we focused on, and design that form really well. So that will take a bit of time. Okay, now having said that, the next one is to keep it going for some time. So I'll stick my neck out and tell you that if anybody is interested, 5-6 of you all get together with a research question, and if Dr. Ashok and others are fine, I'm happy to oversee that and help you get started. Then from there you all can run it. And of course, you need help with data cleaning and statistics, which again you can get, and it should be possible. So I think it's all wonderful to learn things and get excited, being knowledgeable, but knowing is something. But then doing with that and producing data and learning along the way, that would be the icing on the cake. So I would really urge you. I would do two things. I would urge you and also offer you help if you want in setting this up. I'll stop there.
Thank you so much, Dr. Javis. Could we now move on to objective 2 and then keep the house? It's already a little behind. We'll quickly go to open house after that. It's okay, Dr. Dennis. We'll probably not have formal presentation or review of all designs. We'll just let it come through questions in interest of time. Is that okay?
I'm fine with whatever you want.
You could, or if you could finish that in a very short time so that we can queue off people to ask the questions that bothered them across many sessions. That's probably that they want to desperately ask. Yeah.
Right. So we're going to Q&A right away.
We could objective 2. You wanted a few minutes on objective 2 to lighten up.
Yeah, I think maybe 5 minutes we can spend on that. Should be good. Yeah. So you or Dr. Indu, you all can moderate this, and
we had actually told us Dr. Dennis will moderate this, so we're probably not read on that, but we can probably give a shout out to people to kind of come out with, I think maybe Dr. Indu or Dr. Rao, who's got the chits with you, you can request somebody to call out and speak about themselves for a minute, not exceeding a minute, on 1 or 2 of the topics out of the 12 that was listed for them to talk about themselves on. Dr. Rao or Dr. Indu, Dr. Rajshekar, all of you got the chits with you. You can pull out the chits and call out people to share. Unless somebody wants to put up your hand and share, feel free. To refresh your memory, I mean, you were all supposed to, just have a sense about 12 topics. I mean, it was like the place you like the most, or the kind of things you want to do in your life and things like that. So there were a lot of 10, 12 different headings which were circulated a few times in the beginning. And anyone can just introduce themselves. It's a way of coming to know each other. You can introduce yourself and say, these are one or two things about yourself you want to share with the group. Feel free.
Sir, may I?
Yeah, sure.
Yeah.
You want to call out Dr. Achekar? You want to call out?
Yeah. Across the groups, I will call 5 people, sir. Is it okay, 5?
Maybe just 2 for today.
Okay. Sir, I picked up Raj Kiran.
Hello, good evening, sir. I'm from Group A.
Yeah.
2 movies or documentaries? Hello, can you hear me, sir?
Yeah, we can hear you.
Sure.
Okay, 2 movies and documentaries which I liked was one is Chernobyl, other one is Narcos. Chernobyl because we have just heard about this Chernobyl in history, but then once I saw this documentary, I realized what actually is and how they handle the whole situation and the aftermath of it. And then the Narcos regarding the Mexican drug mafia. I just heard about him, but then once I saw the series, it was really gruesome and realized that how bad it was. I think that is the one I wanted to share.
Thanks, Dr. Achekar. Yeah, so to gruesome areas that you would recommend people actually to have a look. Obviously, they are impact the whole world as it were. So, thank you for that. Yeah.
Second one, Sagar.
Hello everyone, I'm Sagar Garag from Karnataka. One person I would like to meet who is alive is Elon Musk. I'm very fascinated by his ambitions in life and to make humans spacefaring civilization. That's one among his contributions to humanity, I guess. Another thing is trying to reignite interest in electric automobiles. Then one dish I'm really good at cooking is it's a salad. I like to make my own salads. Maybe different types of salads. Chicken salad and maybe sometimes.
I'm sure the gentleman is not saying Voddu to you, Dr. Sagar. Feel free.
Yeah, that's all about me, sir. Thank you.
Right. From wanting to meet a very special human being to a very simple salad. And so we have wide-ranging interest there within a given person. I could probably take one more since they've been very economical on time. Maybe we'll keep it open. Anyone now enthused by Raj and Sagar introducing themselves? Anyone would like to come forward and say 2 things?
Sir, may I?
Yeah, go on.
Yeah, this is Dr. Rajiv from IMH Hyderabad, sir. Recently, I have got Facebook notification that 10 years back I have visited Europe, Spain. So that is the first international trip which I have went along with my husband. And that time only we have decided whenever, if possible, we want to go with our kids. So that is one memory with us. And I'm good at cooking. And recently in this COVID time and lockdown, we have got little time to spend with our kids, and I prepared halim, which came out with very good taste. That is the best dish I have made, and my kids also loved it. That's about.
Sorry, we didn't catch the name of the dish properly. We didn't catch the
halim, halim, sir. Halim. It's halim.
What type of this dishes? Is it
Yeah, if I
sweet
may
or
explain.
Chicken halim,
okay?
meat, chicken halim.
We'll give you 30 seconds to tell us how you actually did it.
Oh, you want me to explain? You want me to tell the recipe, sir?
Quick, 30 seconds, 25 seconds.
Oh, so we need to cook the chicken in cooker with all the spices, and we need to grind a few pulses and spices, and we need to keep it along with that. And in a big utensil in a cooker, we can prepare this with a lot of ghee and all the spices, and along with that some barley powder for the thickness. So, but we need to continuously stir it, and it may take around 2 to 3 hours at home,
Okay.
a little quantity for around 4 to 6 people.
Well,
We need to garnish with pudina and kothimira.
Yes.
Coriander leaves.
Islands of information. So the best way to find out about is to visit her and have it in her house. And
Sure, sir. Always
learn
welcome.
from her how to do it in more specific terms. Yeah, thank you so much, Dr. Rajiv.
Thank you, sir.
Thank you. Thank you. Yeah. We can now move on to Dr. Dennis. If you could give a quick 3 to 5 minute review for us on all the designs, and then let all the trainees ask the questions, pending questions on various designs. Yeah. I'm sorry,
Okay.
I'm requesting you just 3 to 5 minutes because we just want to keep some open time.
Yeah, we'll do that. So I put together some key slides from the previous discussions. Let me see. I'll just pull it out in a few seconds, and maybe we can even start from there. So this is called psychiatry research revision. Okay. Okay, revision. So there are several slides here, but I will just go through only a few key slides that I had put up. This is our revision for today. So, so in terms of study designs, as a quick recap, we have quantitative studies. That's what we've been discussing all the time: numbers, measures, statistical inference. And we have qualitative studies. Dr. Rema Devi is here, who did a superb lecture on qualitative, no numbers, and this is for a deeper understanding. So the difference between qualitative and quantitative, in terms of data, purpose, sampling, sample size, methods. I have a little table here. We look at this. So quantitative is numeric. We test hypothesis. Random sampling is usually what is required here. A priori sample size, observational experimental designs. We've discussed this many times. There are several risks, and in terms of analysis is descriptive and inferential statistics, and this is generalizable to the population we are talking about. So we study a sample and generalize it to the population. Qualitative is very different. We don't collect numbers. We collect text, language, observer notes. We try to explain phenomena, and sampling is based on the investigator, and it is purpose of sampling, and it's based, and sample size we discuss this is based on saturation. So when we don't get any more additional new information, we stop sampling further. So methods we use are individual interviews, in-depth interviews, or focus group. There are also ethnomethodology and others. Mainly confidentiality is the only issue here. So we code, categorize, and extract, and then we develop a theory at the end of it. It's not generalizable to the population that they came from, but this is what these people said, and I understood these issues or this phenomena a little better. So PICOT, we know population intervention, comparison, outcome, and time. And this is a template for a research question for therapy among patients with a particular disorder. Does drug A compared to the control, standard therapy, placebo, or drug B reduce certain outcomes? So this is a template for a therapy. So PICO, you can even have a T over a particular period of time. So in terms of study design, this is all quantitative research. We have primary research and we have secondary research. You've seen this chart before. I know it is complex, right? This is systematic reviews and meta-analysis. Primary research can be basic, clinical, epidemiological. And here, to keep it simple, we have experimental study, observational study. Experimental with randomization is an RCT. Without it is non-randomized controlled trial. And in observational studies, if we have a comparison group, we call it an analytical study or just a descriptive study. There's no use doing these kind of studies. Analytical studies, depending on direction, cross-sectional at one point in time, case control, we go backwards, and cohort, we go forwards. Right? There is a bit of confusion about retrospective cohort studies. I'll do my best to explain this. Where do we use these different study designs? Prevalence, cross-sectional studies, and of incidence, cohort. With a cohort study, we can also get prevalence. We don't need to do a cohort study to get prevalence. That's something to keep in mind. There was a question today for you. I think a couple of you got that incorrectly, but most of you got it right. In terms of cause, cross-sectional, case control, cohort, you can do all three, and cohort has the best reliability. Prognosis cohort, natural history cohort, treatment effect only a randomized controlled trial. So in terms of cross-sectional studies, I'll skip all of this. So we have the study population at one point in time, people with and without the disease, with the factor present or absent in each of these groups. Issues, sampling, biases, and analysis. The main bias is recall bias and non-responder bias in cross-sectional studies. Sampling, probability and non-probability sampling is possible. We usually try to do our best with probability sampling. So it's preferred over non-probability sampling. Different methods: simple random, systematic random, stratified sampling, and clustered sampling. We discussed this. Non-probability is convenience, quota sampling, purpose of sampling, snowball, etc. And we can use some of these sampling techniques in qualitative studies as such. So Dr. Ashok, is the train going too fast, or is this a quick recap? Okay.
Enough cues for them to get back to their questions.
Okay. Now you know why I wanted to rest my voice. Okay, analysis of cross-sectional studies. All factors we measure simultaneously at one point in time: exposure, outcome, and confounders. We derive the odds ratio to assess the strength of association between risk factor and outcome. So this is case control study. This is to determine the strength of association of risk factors with the disease as such. Right, so we're looking at exposure and health outcomes. So we have the study population here. We go backwards. We identify the cases and controls. We go to the cases and we ask them questions backwards in terms of exposure and non-exposure, controls as well, backwards, exposure and non-exposure. So this is the case control study design. We have the 2x2 table. We construct the odds ratio. Here's an example that we saw. And if we have this 1,100 patient sample, so we have 100 cases and larger numbers here, but different terms of exposures. Odds of exposure we have, and we get an odds ratio of 2.27. What does this mean? Individuals exposed to the particular risk factor had 127% increased risk of getting the disease. Sometimes we get a little confused. Where does this 127 come from? Suppose you had an odds ratio of 1, means the numerator and denominator are the same. So that means there was no impact, absolutely no impact of the risk factor on outcomes. So here, the 127% increased chance compared to those who were never exposed. This word compared to is critical and must come in. Odds ratio, is this 2.27 significant? So then we compute the standard error, and this is the formula if we are interested in the, sorry, I don't know why this keeps changing. Don't bother about this formula, your computer will give it to you, but this is how we get the 95% confidence interval. And as long as it does not cross 1, it is statistically significant. How to write this? Odds ratio 2.27, 95% confidence interval 1.24, 3.89. Some people put a dash or put a 2. I was told by a very experienced statistician in Canada that it is not completely correct. You will see it even in good journals, but this is the right way to put the 95% confidence interval. Bias in case control study, right? It can be selection bias, non-response and detection bias, observation bias. Mainly, it is the recall bias. To remind you, there are about 75 different types of biases, and 35 of them are common biases. And each study has their own special or biases of special interest, let's call it that. Recall bias is the problem here. And why is this so? Because person with the disease will be sitting and thinking of, I remember I gave you that example of smoking. When I had my first cigarette at the age of 16 on my birthday, I had that rascal of my friend gave it to me. They'll remember that. But the same 55-year-old or 70-year-old man will not remember, without an MI, will not remember when he had the first tobacco exposure. So recall bias, okay, this is the definition, and this is quickly the nested case control study. Right? We have a cohort. Within that cohort, cases occur, and there are non-cases. We take a sample of the cases and a sample of the controls, and then we get a nested case control study design. And while the cohort is ongoing, we can get a little more analysis over here done. So this I gave you an example of the interstroke study that I was involved in. We had about 29,000 patients from right across the world. This was and this is how we report the odds ratios. This is for hypertension, smoking, waist to hip ratio, diet, physical activity, etc., etc. So here is it. So 2.56 is the odds ratio for self-reported hypertension, and 2.98 for self-report plus raised blood pressure. And diabetes 1.67. And we also discussed the population attributable risk. And we can add this all up, and we realize that these well-known risk factors account for 91% of all the risk globally for stroke. So whatever exotic risk factors are still yet to be discovered or measured accounts for less than 10%. So if we can deal with this, that's the meaning of this population attributable risk and the policy implications. Cohort study quickly, population, no coronary heart disease. That is our cohort. Cohort simply means a group of people. It actually comes from the Roman army language or usage. This cohort is here, that cohort is there. If you remember Asterix comics, you will recall sometimes this word cohort is used there. Right. So our cohort is without coronary artery disease. We start off, right, and then there are people who smoke and there are people who don't smoke. People who smoke can get coronary artery disease, need not get coronary heart disease. Similarly, this way. And what are the key issues here in the cohort study? Best way to ascertain incidence. You can also get prevalence. I think that was a question today I asked you. There's a temporal sequence. This is a quick revision of the question that we did an hour or so back. Multiple outcomes can be measured linked to a single exposure. So you realize that if this patient gets coronary artery disease and the patient was treated well, continues on, also gets lung cancer, right? Oh, that can also be associated with smoking, right? So multiple exposures linked to a single, multiple outcomes linked to a single exposure is possible. We can also, useful in studying rare exposures, although it is not efficient design for rare exposures is a case control design, because the outcome has already occurred and this patient comes and lands in your lap. You don't, and then you can study it. Of course, as you know, the evidence pyramid, it is, cohort studies are better than case control studies. Reduce risk of survivor bias, because these people are there. In a case control design, survival bias comes in because people who are dead, you cannot go and get detailed data, although it is still possible to do a case control design in those who have died. Okay. Right, eliminates recall bias because the patient is here with you and you can ask them about what happened now, not after the disease occurred. You're asking them what happened 20 years, 30 years back. Cases and controls will differentially recall it. That is what the meaning of bias is. Disadvantages, time, cost, selection bias, right, not good for rare diseases, although I told you we can also do rare diseases, right? Loss to follow-up is a big problem. Change in exposure. So this, I mean, it's super expensive to be conducting cohort studies, maintaining them, getting data, measurements, back and forth. Right, types, prospective, we collect data going forward. Prospective and retrospective, these are the two types of cohort studies in terms of design. We have that cohort and then we follow them up for the future. Right, and exposure and outcome from this point onwards. Retrospective cohort collects data from existing databases, right? Exposure and outcome from that point forward. I gave you this example and I'll repeat this again. I want to do a 20-year follow-up study of schizophrenia, right? So in NIMHANS, we have 10,000 patients with schizophrenia in the year 2000. I go to year 2000, collect all that data over there. Some of these people would have come that day. Some people would have come the previous week, previous month, but in year 2000, January 1st, there are 10,000 people in the database. Then you follow them up. Now we are in 2021, doesn't matter, but you keep following them up, right? And then you see both exposures and outcome. What can be exposures? I mean, the kind of treatments they've got, other risk factors that develop, their family, and whatever else you're interested in. And you look at, improvement, worsening, mortality, whatever else has happened. So from that point onwards, so cohort is a common group of people. You follow up for certain outcomes. You can do 10-year follow-up, 15-year, 20-year follow-up, and these 10,000. If there are more patients who've come here, you don't add them somewhere in the middle. You want this patients, and remember the analysis we do is patient years or person year, right? So there's confounding where it is associated with both exposure and outcome. This is a big issue with cohort studies. Low physical activity, you get an acute MI. Low physical activity, there's also obesity. Obesity also leads back to low physical activity, and obesity leads to acute MI as well. So obesity is a confounder for low physical activity for the acute MI outcome. Correcting for confounding, stratification, matching, statistical adjustment for confounding. That's the most common way of doing it. Analytical approaches, I told you about, these are 10 patients being followed up for 10 years. This could be 1,000 patients for 10 years. And, they join in at different time points. As you see, this patient joined in even here. And for different time points, they are here. Okay. And right censoring, left censoring, I told you. And in the end, we get person years. How much of data each person provided for you? This person 10 years, 5 years, 2, etc. And then we get 45 person years. This will be 45,000 person years. You get lots of rich data. That pay relative risk is what we look at. And survival analysis. Let me conclude with this one. Interpreting survival data. So summarizing survival data is mean survival and survival rates, as well as person years. These are the common ways in which we do it. Life table technique, we have the actuarial approach. Remember I told you about insurance people, they use the actuarial approach. And we have the Kaplan-Meier approach. Comparison of more than two groups, we do the log rank test. And to adjust for the covariates, we use the Cox proportional hazards model. Summary, I think I'll stop here. That was a rapid fire round, and but I hope that was useful. It's the exact same slides you had seen, and hopefully refreshed your memories. And I've not done RCTs deliberately because it may become a bit too much. We can do that another time. I can do that next week for about 15 minutes, and we'll take questions now. So while I take a breather, maybe some of our faculty can take some of the questions, Dr. Ashok. I can always jump in.
Certainly, yeah. I think yes. Go on. I mean, I think it's good if you just unmute yourself. Don't bother with the chat. Just unmute yourself and ask questions.
Sir, I have a question, sir. Sir, in a cohort, they are giving a retrospective and prospective trial. What is the ambispective trial, sir? I've seen in some of the literature, I've seen ambispective.
Do you want me to answer, or anyone else would like to take it? Dr. Ashok,
anybody, anyone can.
I shall try, sir.
Yeah, go on.
So, sir mentioned that you have prospective trials, cohort studies where you accrue all the cases from this point onwards. You are starting the case, all the participants with and without the exposure. You are starting from this point of time and following up. So retrospective cohort, you have data of a lot of people for quite a long time, and the people you are going back in time. This is 2021. You are going to 2000, year 2000, and accruing a sample with or without exposure. And you should have data for the intermediate period, and you are following them up for various outcomes which you decide at and then accrue the sample. So you have people and you collect the data till date. That is retrospective. But ambispective means you are continuing to follow the same population up. You started from 2000, followed them up till now, and you are continuing the follow up to the future. Am I right, sir?
Okay.
Thank you, madam.
So I have a question. If qualitative research is done at multiple sites by different interviewers, can the data be merged and presented as a single research study?
Mr. Rama, you are muted, I think. If you can kindly unmute.
Yes. Definitely, because in qualitative study, whenever we do multi-site studies, we are not doing just like that. The analytical procedure is a little bit different. And we are going with a standardized tool. So that we should remember. We cannot have an interview guide if you are using qualitative studies, multi-site qualitative studies. We may have to use standardized interview schedules so that there will be uniformity in the data collected and you could do this analysis from the different sites. So never go with an interview guide. Go with an open-ended standardized interview schedule for multiple sites. So easy to analyze across the sites. No problem at all.
Thank you.
May I ask a question? May I?
Go ahead.
Yeah, in studies like it had been said that in any study which has a control group, they are all not case control studies. So how is that how are those studies different from case control studies? Could someone throw light on that, please?
Can you repeat the question, Dr. Smita?
Any study in which there is a control group or there is a comparator group are not case control studies. And we get this confusion when we read journals or thesis. So how exactly is the case control study different from a study which has a control group as well?
Yes. The commonest confusion about whether it's a cross-section study or a case control study.
Yes.
I'll request the faculty from psychiatry, anybody to answer that, please.
Yeah, I think there are RCTs which can have control group. So that is not a case control study. So that is an example of a study which has a control group, which is not a case control study. I don't know whether I got your question right.
I can give an example.
Objective of case control study.
Yeah, I will give an example of what a typical case control study would be. You actually choose your cases and controls by design. For example, I recently reported neuropsychological performance in a large sample of children with OCD. But then I need a control. So I had to choose controls which match with my cases. So I can match them with whatever criteria that I have, maybe match on gender, age, or years of education, IQ, whichever it is. So you actually choose cases and controls and then compare. So both are case and controls, both are recruited by design. So we have another NIMS study where we are comparing, for example, the neuroimaging abnormalities in OCD by comparing OCD patients with carefully matched and recruited controls. So that's a very typical example of a case control study. Now, when I presented the data on a cross-section study, if you remember, it's quite some time ago, I was one of the first speakers. I gave an example of my own work. We looked at, I think they're not best example, but within the patients that you recruit, you identify some of them as controls. Then it's a control, but not exactly a case control study.
The thing is, the case control studies would be specifically looking for certain risk factors that you want to assess, which can be contributing to the condition of interest. I mean, so you're going back to look for those risk factors, and in both cases and controls, you're trying to look for them. I mean, that would be the typical classical case control study. Very many times when we're simultaneously comparing two groups to kind of know differences, they are often cross-sectional studies. Most other comparative studies, they are not interventional studies. The observational studies where they are not going back in time for causative factors or risk factors. All those studies would be falling under the group of cross-sectional studies, observational studies, but definitely they would not be called case control studies. So the key
in fact,
you're looking for risk factors. That's the key thing. Sorry.
No, in fact, in case control studies, a real challenge is not in recruiting cases, in actually deciding how to recruit controls. So the real challenge is to identify right kind of controls for your cases. whereas in many other studies, you will have controls, but then they may not be well matched, actually. They may not have been recruited with a purpose in mind. So being presence of any kind of a control is a methodologically and superior study. That apart, a case control study is much more rigorous, where controls are chosen based on certain criteria to match cases. Therefore, you can actually compare the two groups.
Thank you, sir. Thank you.
Can I add something?
Can I just
sir?
comment to clarify one thing? We have to be, cognizant of two things. One is a comparator and a control, right? So if we have a group of people, I'll keep it very simple without any technical jargon. If you have a group of people, automatically there can be comparator groups in that. Let's take a cross-sectional study, right? So cross-sectional study is at one point in time, although you may recruit for 6 months, 1 year, but it's at one point in time, you're collecting data and you're done with it. Many people get confused. They actually call it a prospective observational follow-up. So in cross-section study, you don't have a follow-up. So you have a group of people, and in that, naturally, within that group, they fulfill that eligibility criteria, they get in. Within that group, you have people with exposure, without exposure. Then again, you have people with an outcome, without an outcome. Since you're doing it at one point in time, you'll just do an odds ratio, and you have the strength of association of what you're interested in, the factor you're interested in, and the outcome that has already occurred in some group of people, right? So these are the comparators. So these are not controls. Again, in a cohort study, now where do you get a control? As Dr. Janardhan Reddy correctly said, you take a group of people and you look for controls. You're looking for them, and when you look for them, you need to match them. So typically, you get a control in a case control design, right? Now, in a randomized controlled trial, what happens is you have 2 or more groups, you have an intervention, and you have another group without the intervention. That can be called a control over there, right? So sometimes people, they try to, get a group of people, and then from somewhere they find, controls, and then they want to match them and they want to analyze them. And as Dr. Janardhan again correctly said, the biggest problem is getting the right controls, and all the problems come up over there. I'll stop there.
Thank you, sir.
Sir, I have a question, sir. May I please ask?
I think Sagar also has a question, but Rajshekar and then Dr. Sagar. Yeah, Dr. Rajshekar.
Yeah. So a common problem we face during EC submission is the word cross-sectional or prospective. Like many times we have seen, like in the EC meeting, especially the SPM faculty who are sitting there, they are not very comfortable accepting the word prospective. Is there a minimum specified timeline? Like my understanding is, if I'm seeing a patient now and if I'm reassessing after 1 hour, that is a follow-up study. Can you please give your comments on that?
I mean, it is not really like that.
Okay, sir.
I mean, I see after 1 hour, it doesn't become a prospective study. That is taking the definition of prospective into an extreme extent. But prospective studies are typically the ones where we follow up patients over a period of time, or we do things over a period of time prospectively from now on. It could be 3-month follow-up or a 6-month follow-up, or that typically follow-ups occur at least over a few months rather than over a few hours. Now, irrespective of what ethics committee feels, these definitions don't change. Then I think ethics committees have to be educated. There's no option at all.
Because even with these 3 months, they are not ready to accept that they still want to put it as cross-sectional only.
I mean, it depends on the research question you ask. You want to say, what is the 3 months outcome of a particular intervention? Of course, it is a short-term outcome, but still it is a prospective study because you're recruiting people now, and then you are reassessing after 3 months. It could be 6 months, 1 year, 2 years. So, but then it can't be after 1 hour or 2 hours. I don't know. I mean, maybe studies of particular designs may allow even that, but I don't know. At least in psychiatric research, prospective studies mean patients being followed up over a period of time.
Dr. Pratap?
I think there is a difference to be made between prospective and retrospective and cross-sectional and longitudinal. The cross-sectional doesn't contrast with longitudinal. prospective, one can have a prospective cross-sectional study also, in the sense that if you start your data collection after your methodology has been firmed up, it's a prospective study. If you are looking at data which is already collected, that is a retrospective study. If prospectively, if you do a cross-sectional study, that is a one-time data collection, and if you are doing follow-up studies, that will be considered a longitudinal studies. But this is my understanding.
Yeah, I think that's rightly put actually, yes. Prospective longitudinal studies are any data that's collected from onwards becomes a prospective, but yes, I think longitudinal component is the most important one. I agree.
Sorry. Dr. Sagar, you had some. Yeah, Dr. Sandeep, yes, go on.
No, I think what Rajshekhar is asking, again, we need to understand that what he was asking after 1 hour or 2 hours. Suppose somebody is trying to evaluate the efficacy of ketamine. So you're carrying out 2 or 3 assessments and registering them. So the basic is that if you are carrying out multiple assessments in a study, which technically becomes a longitudinal and also prospective. From that point of view, it will be basically if you have more than one assessment being done, then it should be considered as a prospective study.
Also the thing here is certain differences if they are observation studies or intervention studies. Intervention studies, then prospective, longitudinal, it takes a different meaning. But observational studies, I mean, they carry a different meaning. And observation studies, you're just finding people with a particular condition and you're connecting them with certain aspects of your interest. Those would be cross-sectional studies. You can have comparator groups with or without the illness or another kind of illness or something. So there will still be cross-sectional studies. But for case control studies, again, observational studies, but they need to actually go back in time to look for factors that you think are risk factors for the topic of interest. So very often case control studies are really exploring risk factors contributing to the condition of interest. And I think so. It's a totally different matter. If you're giving some intervention and then following up, then it's an interventional study. Then those words like cross-sectional and observational can be, they not really be technically feasible. You actually look at, prospectively you assess the outcome of a particular intervention. Probably. So maybe those are things to be kept in mind. Dr. Sagar?
So my questions regarding case control studies. On one hand, we have propensity matching where there's examples of matching to 200, 250 factors. Then on the other hand, we have something called over matching where we don't have to match more than 2 or 3 factors. So what is the sweet spot and what are the indications for propensity matching when we need to undertake propensity matching?
Any of the faculty can take that. Would you like to clarify the word propensity matching? Because I personally am not familiar with that.
There is a propensity score, and then based on the propensity score, that score is arrived by matching certain factors, maybe basic socio-demographic factors, then certain clinical factors.
Dennis can correct me. I don't think you select controls based on propensity score. I think propensity score is something that is derived after you decide how you actually choose controls. And how do you choose control? I mean, at least in psychiatry, most commonest method of choosing control is you match them by plus or minus 2 years, and gender matched, ESF education, maybe IQ or socioeconomic status. So you have certain broad demographic characteristics which you actually employed to identify controls. And I think propensity score is something different. I don't think that's used for selecting controls in a case control study. I think Dennis can clarify that.
Yeah, I'll come in here. I did speak about the propensity matched thing here with registry. So these are actually two different things. So we'll have to actually look at the study, the research question, the study design, and then understand the other aspects related to this. So propensity matching is done in a cohort, in a group of people with something in common, and within that group, you want to make some comparators, right? So you don't go looking for a control there. So in propensity matching, you have many different factors or parameters, and then you have preferably a large data set. Only then this propensity matching really works out. And if you hit a particular cutoff, and then you say, okay, by propensity matching, I will do the comparison between these two, right? So this is in a cohort study, and we explained this during a registry today. Case control study, you find a case and you define it, and you find a control, right? And then you actually bring up a very important point, Dr. Sagar. You find a control which is similar to the case except for the disease, and you match usually for age and gender, rarely a third aspect, and you need to really get to that. So the interstroke study that I told you was just age and gender matched. And that is where you have to be careful. In a case control design, you have to be cautious about over matching. I remember having this discussion. I said, no, we should match on this, we should match on this. So many of us learn things the hard way by making mistakes. So I was very keen on matching for this and this. Then I learned both by faculty and by reading later on that you don't match on too many factors. Then it becomes over matching, and then what you're trying to find out, you will begin to dilute it. Is that okay, Dr. Sagar? So in summary, cohort. Sorry, just to summarize, in cohort, in a group of people, you have large number of parameters. You take that and then you develop a propensity match, a propensity score, and then you match based on that. And then in a case control study, you have a case and then you find a matching control. And here is where you don't match on many parameters. Usually age and gender, age plus or minus 5 years, and the same gender, you go ahead. Maybe one more parameter you can take for. I'll stop there. Yes, Dr.
Thank you very much, sir.
Yeah, I think I was trying to say the same point, that if you match too strictly, having too many factors for matching, you get super healthy controls, and that has the danger of amplifying the differences between case and controls. So this is very common in psychiatric research. For example, if you're doing imaging studies or neuropsychological studies in psychiatric patients, if you take super normal such healthy controls, then you will actually amplify the difference. Whereas your controls have to be as close to general population as possible, barring some key exposure points, and then they're similar to the cases. So I think this is something which has been discussed in literature quite often in psychiatry, that avoid super controls or super normal people. It has its own problems.
Can I ask a question? Can I ask a question, sir?
Sure.
So my question is, in hospital settings, generally we go for consecutive sampling. Can that be considered as random sampling or non-random sampling?
Anyone would like to take that up?
So I'll stick my neck out and say that it is not. It cannot be considered as random sampling, but I see that almost majority of the studies that are done in clinical settings do this consecutive, or sometimes what can be called as convenience kind of sampling. I think they come with a lot of inherent problems. So it can be a proxy for a random sampling, but it cannot be considered as a strictly randomized, random sampling, in my understanding.
So then I'd like to add another part. How can we, in a hospital setting, how can we go for a random sampling first? People are coming to the OP. How can we go for a random sampling?
I would say it depends on your question. Like for example, if you want to select a group of patients with a certain diagnosis, let's say you have 10,000 registrations of a particular disorder, but you want to study a cross-section of them, then you can use a computerized random number generator to pick out random sample of about 100 from the 10,000 that you have. I mean, it really depends on your study design, but I'm giving one example.
So in places like ours where we don't maintain the records of OP patients, IP we do have, So if you don't have the OP records like that, and we have to recruit patients who are coming to you. So what other option do we have in such situation?
I will suggest one other option. Again, it is not a strictly random sampling. That instead of taking consecutive patients, you can take every 5th patient or every 10th patient. So that can come early to making very different from people from when you are able to choose the OP. For some people are
You're not?
Can I come in? Can I have my?
Yes, Dr. Rama.
I think in hospital outpatient clinic, what I would recommend is consecutive selection. Consecutive selection is not anywhere simple random sampling. It is not random sampling at all, but it avoids the bias in selection. So you could do a consecutive selection, and as he pointed out, you could do a systematic sampling also. When you do a systematic sampling is appropriate when there are too many people in the outpatient department that you want to select, and you have not time to recruit all of them. So in that case, you may go in for a systematic sampling. Otherwise, I think it is nice to have a consecutive selection. It avoids the bias in selection, but not simple random sampling.
I have one additional suggestion. If you are doing a consecutive sampling, it is practically impossible for you to consecutively recruit everybody who comes to a clinic. And I have seen numerous papers writing consecutive sampling. I'm sure it is not true. Now, what is important is, let us say, if 10 patients with schizophrenia come to a clinic, you are able to recruit only 5 today, for whatever reason. I think the patients that you could not recruit also needs to be noted down. And I think their basic clinical and demographic characteristics should ultimately be comparable to the patients that you recruited. Then I think your population may be at least representative of the patients who come to your clinic. So people whom were not recruited in the study are also important here, so that we can say that the sample is representative at least of the clinic population.
Dr. Ashok, could I just make one comment on this? And unfortunately, I have to leave now.
Yeah,
so
sure,
on
sure.
this question, which I know Dr. Sandeep put up his hand before me, but if I could please request you. So actually, this question Dr. Indu asked, is important because many people write, consecutive, and as Dr. Reddy just mentioned, people keep writing this. I would say technically it is not feasible to recruit consecutive patients in any OPD, anytime, in any place. Okay, so the ideal sample is the universe. We want to do everybody. It's not possible. Because you cannot study the universe, you are studying a sample. Let me go back to Dr. Indu and actually challenge her with this. You're going to take consecutive patients on Monday, Tuesday, Wednesday, Thursday, Friday, Saturday?
Not possible.
From 9 a.m. till 6 p.m., every single patient who comes to your clinic, if you can do that, and will you be doing that for the whole year? Or you're going to do only on in January and February? Are your patients in January and February different from November and December, or So theoretically and even practically, it is not possible to study the whole universe. That is why this whole issue about sampling comes. Right, and therefore we have to have a simple, practical, and a technique or a strategy for sampling. And of course, we've discussed the different strategies for sampling. So consecutive patients will not work at all. So better to have another strategy. So with this, Dr. Ashok, may I be allowed to leave? And then I'm available. I mean, maybe other faculty can continue for a little more while. There's a deadline for a paper, so I need to get some nutrition, and then I've got 2 calls already. I have to do that file review, and tomorrow something else as well. So thank you all, and really lovely seeing all our faculty, Dr. Sandeep. Although I couldn't see Dr. Reddy, I only heard him, and Dr. Rama Devi and others. So thank you. Always a pleasure to work with you all, and the rest of you all. I'll be there. You are, Dr. Reddy. Thanks. Nice to see you. Right. So we'll catch up soon, sir, and I'll excuse myself. Yeah. Thank you. Bye.
Yeah. I'll request
Ashok,
Dr. Sandeep.
Ashok, I will also take leave.
Sure, Dr. Yes. Yeah, sure. Thank you. Thanks,
No.
Dr. Sandeep, and Dr. Sandeep, and then one query by Dr. Lakshmi. And with that, we'll probably call it a day. Dr. Sandeep, yes.
Yeah, I agree with all the observations made that it is impossible to do the consecutive sampling, and whoever is writing that they are doing consecutive sampling from the OP, it is practically not possible for anyone. Yeah, in few situations you can still do it, provided, for example, you are trying to collect a data for starting a particular intervention. For example, at my center, I often do that. If you are doing a study on taking patients who are going to be started on clozapine, but there also we end up missing out few patients if they are started by somebody else. So it is not possible from that point of view. But as a principle, as Jagdisha told, that you can use a random number table, or maybe that nth patient of a particular day. Maybe that I go to OPD every day and I recruit the fifth patient with that diagnosis on every day of the OPD. That's still a better strategy rather than using very open kind of a strategy, or every first patient of the with that diagnosis in the OPD that day. So that is still a sampling method which I am trying to use, by which I can still justify my sampling.
Possibly in an inpatient setting, that might, the consecutive sampling may be more feasible. I mean,
yeah, in patient setting, that is definitely feasible. Or like something like you are collecting data from the ECT services. There, the numbers are fixed and you have access to them. There it is possible. But from an outpatient and any one diagnosis, it is practically not possible.
Thank you, Dr. Sandeep. Dr. Lakshmi, and then Dr. Shalini also has a question.
Yeah. Sir, I had a question on registry, taking forward from what Jagdisha sir had asked me. Suppose I take out files of 200 women who have attended the clinic in the last, say, 1 or 2 years, and I form a database. Will that become a registry, sir? Is that all that I have to do for forming a registry? And I wouldn't have asked consent for these patients. So is that again a problem?
Can I just try to answer that?
Sure, sure.
From that point of view, it will not become a registry. Registry, you prospectively formulate a plan, and then you keep on adding the data there once every patient is being coming for that one particular term and condition to you. Here you are retrospectively just collecting the data and then trying to analyze. So in registry is an ongoing process where you keep on adding patients with that one particular condition which are coming over the time period. What you're trying to say is it's something like looking at the retrospective data that may not be in real sense a registry from that perspective, but the data has not been collected in a particular format right at the beginning itself.
Yeah, for a registry, you need to be very clear about the number of parameters that you want to, the minimum number of parameters you want to definitely have about the patients, and you need prospective manner. I mean, I think that's a key difference. Dr. Dr. Lakshmi, will come back to you. Dr. Shalini.
Yes, sir. I've come across something called as addressing missing data in case control study. I was not sure how to conceptualize, because missing data, I thought it was only in cohort and interventional studies where people lost a follow-up, and then we address that. In case control study, what is the missing data?
Yeah, can I try to again answer that?
Yeah, Dr. Sandeep, yeah, sure.
Yeah, basically the case control study is a retrospective study. So all the data may not be available for all the patient. That is the basic issue which you need to understand. So from that point of view, there could be some missing data as far as my best of understanding about that case control design. That because the data, the events have or things have already occurred. So some of the information may not be available.
Yeah. And sometimes missing data can also be an artifact of, actually data entry and so on. So those can also be sources of missing data when you sit down for the analysis. Yeah, then Dr. Natarajan.
Sir, I have a question for Professor Emma Madam, sir. I have a difficulty in understanding about the concept of data analysis when doing a qualitative study about this grounded theory approach and this content analysis. Can you please enlighten me, madam?
Pardon? Data?
Content analysis and grounded theory approach in doing a data analysis.
Content analysis.
Yes,
I think
madam. Yes,
content
madam.
analysis is only a preliminary type of analysis where you, in a deductive approach, you develop your categories prior to going to data collection. But here, in an inductive approach of study, you develop your categories after the study, after data collection. That's all. That's the simplest form of analysis. But grounded theory analysis uses there are certain characteristic features for the grounded theory. The analysis, constant comparison, theoretical sampling, and then this open coding, axial coding, and selective coding. These different inductive coding processes are there. All these are different. In a simple content analysis is just you develop your categories once this data collection is over. So that's the simplest form of content analysis, qualitative content analysis. But grounded theory analysis is different. It has got several characteristics. So the sampling is different. It's not opportunity sampling, it is theoretical sampling, and this constant comparison in the analytic process. And also, as I pointed out, is open, axial, and selective coding process. And at the end of coding process, you develop the theory. You come out with a framework. That is the difference. So in simple studies, sometimes people do the content analysis, and in other these inductive coding process, the GT, and in thematic approach, the analytic approach is thematic. Okay. But this with simple thematic analysis, in several other studies we do, where we need not go in for a constant comparison and theoretical sampling, which is characteristic of the grounded theory approach. But the analytic approach is thematic analysis. In all thematic analysis, we do have this open, axial, and selective coding process.
Okay.
Thank you, Dr. Rama. Yeah, I think we really wish to close this at 7 o'clock. So I'm sure you'll have more questions. There will be sessions coming up where you have more opportunities to ask these questions. The next session on 20th will be again led by Dr. Dennis and Dr. Pratap Tarian, ex-professor of psychiatry from CMC Vellore. The focus will be on systematic reviews and meta-analysis. And the journal club will be on cohort studies. The group that is going to present, you can just identify yourself. The cohort studies.
Group B will be present.
Group B will be presenting on the journal club on cohort studies next Sunday. So kindly by tomorrow morning, try sharing the journal. If you have already shared and I have missed it, it's okay. If you're not, kindly share it by tomorrow so it can be sent across to all the judges and so on. Yeah, so with this, we end the session today. Thank you all. Thank you so much to faculty, Dr. Jagadisha, Dr. Sandeep, Dr. Janardhan Reddy, Dr. Ramadevi, Dr. Pratap for all joining us today. Thank you. We hope to request your participation in some of the later sessions also. So thank you. I know there are many more questions, but you will definitely have more opportunities to ask these questions. Thank you and good night.
Thank you.
Yeah, and so even the RCBC members will probably discuss via either another link or probably on the WhatsApp group itself will continue the discussion. We may not be able to continue on this platform right now because we need to really close at 7, as I understand. So all of us can probably take leave at this point in time. Thank you. Bye.
Thank you, sir.